So, a very, very, very warm welcome to everyone for this kind of conversation about safety 2 and resilience. What we have is, firstly, a thank you to the Q community and Matthew and the Health Foundation for organising this and providing the platform. And what we're going to do is introduce myself along with Simon and Paul, who are going to be my co-hosts of sorts, and we have an hour together to explore some of the things. What that'll be, we'll have a short time for reflection, as well as 3 questions that we would like to discuss. And at the very end, I'm absolutely certain that what we'll want to do is explore this topic further. And so at the very end, what we want to do is talk about next steps and what that might look like. So if you are really interested in this subject area and the way in which we could look at things differently, then if you stay to the end, we can start talking about how could we continue to have that connection and that network. And this is as much about us listening to you as it is as speaking. So this isn't going to be lots and lots of presentations and then a very small 5-minute Q&A at the end. This is much more about drawing out your experiences. So we want to listen, as I say, as much as speak, and we're here to learn. I think that's the whole beauty of the whole world of safety. It's continually learning. And so the first thing I'm going to do is invite my co-hosts to unmute themselves and to introduce themselves to you all as to who they are, and then they'll come back to me and then I'll explain a bit more about me and what I would like to say. So I'm going to start with Simon. So I'm now handing over to Simon to do that.
Hi everyone, thank you very much for joining us today. It is amazing to see such breadth from the UK, but also I've noticed representatives from Singapore, Norway, Germany, Hong Kong, Canada, and I'm sure there are others that I've missed, so welcome to you all. What we're wanting to do is talk a little bit about safety 2, resilience engineering, whatever you'd like to call it. I've come at this from aviation. I'm a human factors specialist and have really been on the front line of applying safety 2 and resilience engineering in aviation and trying to understand how we can bridge this gap between what we think people are doing and what they're actually doing, and really understand how that deviates and why it deviates. I'm increasingly working with healthcare professionals, and that's what led me here. I was working on a project and someone said, why are we talking about redesigning clinical spaces when we should be looking at the adaptations that are happening today? And that's really where we started looking at this to try to solve problems for today. Yeah, look forward to the conversation today.
Okay, over to me, Suzette.
Yep, sorry, I was muted. I didn't. Over to you, Paul.
Thank you. Well, good afternoon, everybody. My name is Paul Stretton. It's really nice to be here and to speak to so many people around this topic. I'm a safety scientist that has a business that works with a number of high-risk organisations and industries on civil engineering, rail and healthcare. Over the years, I've adopted various safety 1, safety 2 methodologies, and increasingly come to see safety as something that an approach that I call quantum safety, which is an integrated approach between both safety 1 and safety 2, but also increasing with the organisations that I work with, trying to understand how complexity systems affect our safety performance. So as part of my work, I recently had a paper published called the Lily Pond model, which begins to create that framework where we can understand the adaptations that Simon just spoke about and move away from using linear models to try and understand a complex system. There's a lot of fantastic work that's happened over the last few weeks, and I'm very interested in listening to your experiences and finding out how we can understand how safety to resilience engineering and complexity can help improve performances in your organisations.
Brilliant, thanks, Paul. And the Lily Pond reference that Paul mentioned is going to be at the very end, so don't worry about asking yourselves where on earth is that. We will give you the link for that. So we have had some pre-Zoom questions, which pretty much predominantly say, oh, what is this safety 2 business? How can we actually do safety 2? And how appropriate is it for various aspects of healthcare and so on. One of the questions in particular talked about an example of the way in which we are changing our practices, and is incredibly pertinent. Talked about the fact that their father had died of COVID-19 and that the Red Cross had offered to help them with facilitated group video calls. And that's a very, very, very timely reminder to reflect. And one of the things that I thought was really important that we did in this call was not to talk about how exciting all of this is and how brilliant and amazing this platform is that COVID-19 has enabled us to think differently. We have to realise that COVID-19 has affected everybody significantly in so many ways and in so many awful and tragic ways, and it's important for us to recognise that the opportunities that we may have as a result of all of this are built also on sadness and on people's struggles. And if we don't recognise that, then we won't, I think, move forward in a really responsible, respectful and kind way. And so the importance for me about safety 2 comes back to its philosophy, really, which is it is a very different way of looking at safety for me. I think it's about taking a much more positive approach to safety that is respectful, kind, fair, and really starts to try to understand why complex adaptive systems sometimes fail. And I think I use the word sometimes because that is the main. It is in the main we get it right, and in the main things go okay, and it is rare that things don't. But unfortunately what we live in is a land of what is coined as safety 1 by particularly resilience engineers, which is very much based on looking at failure, and that we measure all of that failure and then we try to reduce the amount of mistakes and errors and therefore the complaints and incidents that result from all of those. And it has dominated our healthcare industry and other healthcare industries in that approach. And that we've used these linear models, and what we mean by linear models is that it simplifies or thinks that you can simplify healthcare into steps, and that if you have steps, you can therefore look back at those steps, as well as thinking about the future steps. But actually healthcare and an awful lot of high-risk industries are much, much more complex than that. And there's these multiple interdependencies in relation to people and things and the environment and the situations. And that's why COVID-19 has been such an eye-opener in terms of really showing us how complex healthcare is, but also how absolutely astonishing it is the way in which staff have been able to think through what they currently do and adapt and adjust. And so that therefore moves us on to safety 2, which is very much looking at where we fail, of course, and that's very necessary, but also where we succeed and how we succeed. And as Simon says, it's looking at those adaptations and understanding how we do that. Adaptations or adaptations, however you want to describe them, and how do we do that and why do we do that? And that's in our actions and our behaviours and our choices. And so the difference between safety 1 and safety 2 is that one is looking at failure and trying to prevent that failure, and the other is looking at how we succeed and how as much as possible goes right. And how we adjust and adapt every single day is how we try to achieve that. And we know that people are doing it even when they don't notice it. And so what we do in respect of adapting and adjusting in healthcare is that we do it without noticing it, we do it with habit. And I think that's one of the interesting things, again, about COVID-19 is that we've had to think differently, and therefore we might be noticing it more, which is, I think, why it might be a way in which we could notice more about our adaptations and our adjustments, because it feels new and therefore we're noticing that. And as we've heard, people are working in multiple different roles and different situations in different places as a result of the pandemic. And people have had to try to interpret policies and procedures very, very differently, and then being given different policies and procedures on the hoof. And that's, again, a kind of ongoing process. So I think the importance for me is to think about the framing of all of this. I think the pandemic has reinforce the urgency of our purpose and the emerging new possibilities for, in my world, safety, but also noticing that in the midst of a crisis, how things are different and how we talk differently and how we move differently, how we act differently. And I think it is also a moment in time to reflect on what kind of world we would want to build as we move ahead. We've seen very deeply how much we need each other and how much we need across the whole system, no matter where you work and who you work. And I think we've also seen how deeply people have thought through how they might want to change what they're doing and how they particularly might not want to go back to certain things that they found really hard to do. And so I think as we're going through this crisis, because we're still within it, we can notice what we're doing and think about what about those things that we used to do that we might not need to do? What can we stop? What can we start? What we can change? What can we do differently? And that's very much based on the adaptations that we may have been taking, again, without necessarily even noticing it. Because I think there is a potential for some lasting change associated with this, certainly for my world of safety. So for those that want to know about safety too, that's a sort of mini summary of it, but there's a ton of references that we're going to share with you. But one aspect of safety too is sometimes even the word. So if there's a safety two, there's a safety one, and is it either or, and it's both. And I think it's important just to remember where it comes from, and it comes from resilience engineering, in particular, people like Eric Holnagel. And I think that's why I would like to now hand back to Simon to explain the kind of work that he's been doing in resilience engineering that kind of builds on what I've just been saying.
Sure. So what has been evident as I've been having conversations around the healthcare system in multiple places is that adaptations are happening at all levels, as Suzette said. They're happening so fast and they're happening so naturally, but we're not always recognizing how significant they are. So we have examples of big adaptations, so big solutions, if you like, Blue Dot in Canada, and anticipating and modeling outbreaks. And then we've got quite structural ones, so procurement rules being relaxed very, very quickly, very easily in order to allow PPE delivery from small suppliers. And then we've got these very local. So we've got a healthcare provider requiring face visors, so an open sourced face visor being found, and a very small workshop running off some visors to be delivered. These are happening all the time, and what we're trying to do is we're trying to work out a mechanism by which we can capture and share these. So capture and share this good practice, but also find ways in which we can really help people to log challenges that they're facing, because I have absolutely no doubt that people on this call will have solutions to problems that others on this call are facing. And what we're trying to do is work out the best way to facilitate that and to create the community that allows us to share those adaptations. So we haven't come with an answer today, unfortunately, but this is really the start of these conversations to see how we can start to share it. I think this point about that you were raising about resilience and resilience engineering and safety too, you will hear them all mentioned, and different people use them in different ways. I think critically, resilience is about how the system adapts, that a system is able to adapt to a disruption of some description. Resilience engineering is the solution that we put in place to either facilitate that adaptation or to manipulate that in some way. It is an engineering solution, but the way in which I tend to look at it is that resilience incorporates safety, but it also incorporates quality improvement. It incorporates more than just safety, and obviously safety too is very much focused on the safety aspects. But inevitably, when you improve safety, you're improving quality and improving effectiveness. So it's really hard to sort of pull them apart, and really you can see them being used interchangeably. But we don't want to get too caught up in the terminology. So if you have any questions, by all means, drop something in the chat and we'll respond.
Thank you, Simon. And Paul, I know that you've got 4 points that you wanted to share with the participants today, so I'll hand you over for you to share those.
Okay, thank you, Suzette. Yeah, I think building on what Suzette and Simon has just said, from my point of view, and speaking to both Simon and Suzette over the last few weeks or so about this, there were a few things that came to me immediately. The first thing is that when someone talks about the resilience of the system, just how remarkably resilient the healthcare system has been, with obviously unprecedented, has been used in an unprecedented manner over the last few weeks, but the resilience of the healthcare system has been astonishing, from the Nottingham hospitals to the flexibility of the various professionals. And I think one of the questions that Matthew sent through at the start actually is one of our challenges now, if you're interested in quality improvements and patient safety, is how do we keep that zeal for change and that energy within healthcare afterwards. When we talked about the adaptations and capturing those adaptations, which Simon rightly said there were many happening at various levels consistently. I've got one note of caution for us when we're looking at those adaptations, and that is to try and recognise the context in which they are made. I think in some ways the systems that are being adapted now have become, as a result, less complex. The presentation of our ICU patients will be very, very different to a normal ICU situation outside of the pandemic. And so it's important that we understand what the adaptations are made in that environment, and then what can we take away in a new normal post-pandemic. And I was interested when Suzette was speaking about the difference between safety 1 and safety 2 and where we learn. And for me, one of my biggest difficulties when we're looking at improving is we get our approach is dictated by the score or the outcome quite a lot. And if it's an acceptable outcome, we minimise the opportunities to learn. Or obviously, if it's an adverse event, then a lot of our safety 1 machinery kicks into action. So very quickly, a recent example that I came across, there was a specialty team that were known to be very difficult to work with, and there were numerous issues, bullying, harassment, things like that, that got raised to the appropriate person. And there was a short meeting, but they opened up with a service manager saying, I know people are difficult, but we are not going to do anything in terms of addressing the difficult personalities because their outcomes are so good for the patients. So it doesn't really take into account the impact that has on all the nurses, the junior doctors that they're influencing over a huge amount of time. So I think too often we dictate by the score rather than by the opportunity to learn. And finally, the importance, I think, when we're looking at the COVID-19 situation, in terms of safety 1 and safety 2, safety 1 encourages us to learn from adverse events, and this is going on one of the biggest adverse events that we'll ever experience. If all we do is measure, record, and learn from those failures, I think as Suzette delicately put it, I don't think that's a particularly respectful or effective way to learn from, particularly recognising all the effort and adaptations have been made by so many professionals throughout the healthcare sector. So for me, if we're going to safeguard our professionals and raise patient safety, we need an integrated approach of both safety 1 and safety 2, that we can drive improvements and learn from this event.
Lovely, thank you, Paul. So you've heard from a little bit from me. It's quite hard to describe all of this in a very short webinar, but you've got a taster from myself and Simon and Paul about the sort of things that matter to us. And what I would like, and Matthew, if you can pop the reflection slide up, what I'd really like for us to do is to kind of hear more from yourselves. And Matthew's going to pop up a slide that's going to be called reflection. So this is basically my way also of us reflecting just for 1 minute of our time on the people who have died and the people who are struggling all over the world, in fact, in relation to this. But also on that reflection to think about the kind of world, and as it says here, and kind world that you want to build as you move ahead. I think it's really, really important, as it has so beautifully put by James Kerr in a book called Legacy, which is it's important to connect your past. It isn't about saying everything that's gone on in the past has been wrong. It's about saying, well, we're now learning from that and we might think differently. But in relation to the past, the conditions before created or revealed by the pandemic is useful for us to reflect on. And then to the present, the sort of living in the here and now, what is your work has done? You know, this phrase that is used in Human Factors, what is that work has done? What do you and your team do now? What have you achieved, what you can achieve, and what do you need to do now? In order, if you look at that past and you look at the present, to think about your future possibilities and the possible changes that we could do based on your experiences and not what we imagine your experiences are. And I think that's the one important thing that we wanted to share, was that we're not you, and we haven't, and every single one of us has had a certain experience of all of this. And that's why it's so important to hear all of these diverse opinions, diverse voices, diverse people, in order to think about what we might want to do for the future. So at 12:55, what I'm going to ask is all you do is reflect for 1 minute on everything that I've just said. Okay, thank you. That felt important for me, and I hope it was important for you, in order for us to now think about, well, what are the questions that we could ask? And these are early days questions, and as Simon said so beautifully, this is the start of a conversation, the start of something. So if we can move on to the first question. The first question is clearly telling you, quite rightly, that we all are adapting and adjusting our actions and our decisions all of the time, even if we're not aware of it. And I think some of you have been posting this already, but can you think of ways in which you have adapted your practice over the last few weeks that have made a beneficial difference to the care that you provide? So if we pause on question 1, let's have a little look at the chat room to see what answers there are coming through. And I know, Simon, that you've actually noticed a few, so I'm going to pass over to you to pick out 1 or 2 that you actually have noticed already.
Okay, thank you. Yeah, as I say, I mean that there are multiple, and just picking up on John's comment from the chat. John O'Neill said that they're changing practice. They have been debriefing and using new means to do it. So updating and planning constantly via WhatsApp. So it's instant. You can continually discuss adaptations, changes, update on whatever, but it's instant. It's there. It's recorded. But it's also about debriefing. So you can use, as John mentions, team meetings to really understand what has gone well, what hasn't gone so well in the period. And this is very similar. It's actually, so many of these adaptations overlap. So we're also talking about with a healthcare organization in the US who they're trying to maintain social distance in debrief rooms and so on, and how you can still achieve that. So getting other people involved to understand how they can adapt clinical spaces, both for different clinical reasons, but also for meeting reasons. So, I mean, there are so many of the examples: gin distilleries making hand sanitizers, garment houses using adapting to sew scrubs. We've got multiple examples at various levels of how this is being done. Within general practice, one of the biggest changes has been the widespread deployment of telehealth consultations. So how quickly people that were previously very adverse to that kind of solution have adapted it and incorporated it. And from my discussions with GPs is that we're unlikely to go back to the way we used to work without telehealth consultations. So I think there's a couple of examples there within a clinical setting, but there's also within testing. There are DIY biology communities collaborating over open source testing kits, and then you've got really sort of really interesting and valuable work to support the people on the ground. So there was a rapid escalation in the rollout timetable of people.nhs.uk, which is an amazing resource to help those that are facing the difficult decisions every day. That was a project that's been going for some time, but in the face of this crisis, they escalated it. They've rolled it out very quickly. There are guides available, and I'd encourage you all to have a look and to share it with your colleagues. So I think there's a few examples, and I have plenty more. It's really the challenge that we have is how to pull these together and to share them widely. And I can explain a bit more about what we're thinking about that later on in the call.
Yeah, absolutely brilliant. And one of the things that we all wanted to do that when we were planning for this was to look at the themes or the threads that run through a lot of the ways in which people have been enabled to adapt, and therefore how that they can persist. I think the underlying conditions are really important for me. So one of the things I'm seeing in the examples people are sharing is aspects of behaviours or both individuals, teams, but also the way in which organisations behave, but you know what I mean, in that, so are people being given the permission to make those changes, or are they doing them, as so often has happened, sort of behind the scenes, and let's hope nobody finds out that I've actually adapted something when in fact I should have been doing something else. And it's about being given the permission to be able to do that and being trusted. So there's that element of really good compassionate leadership that knows how to delegate well, is a good theme for being able to enhance these adaptations. So permission, compassionate leadership, giving people clarity, but also allowing them to be flexible, trusting them, and crucially throughout all of these, I can see is the listening, and making sure you are truly listening to people about what it feels like, what they're experiencing, and what they need. And so it does always boil down for me is what's our shared purpose across all of this. And our shared purpose in healthcare is to deliver the very, very best care that's within our gift, and therefore safe, effective, efficient, high quality, and so on. But a crucial thing for me is that we care for the people that do all of that, and that we make sure that they are looked after, listened to, and cared for. And some people have also picked out the psychological impact of safety too, which is incredibly important, as well as these sort of physical or technical or operational adaptations people are doing. There's something about their psychology, their emotional needs, and so on, that people are also picking up, which Debriefing, if done incredibly well, does that superbly. So thank you for all of these, and what we'll try to do is bring out all of these along the way. So we'll move on to question 2, which is very much sort of building, which is in thinking about all the adaptations that you make. So Matthew, if we could have question 2, that would be great. But in thinking about the adaptations that you make, do you see that these are temporary, that are, we adapted and now we're going to go back? Or is there any emerging new possibilities that you feel that we can actually make these both spread and sustain? So what would you like to continue that you'd want to sustain for a long term, given the fact that everything is complex and constantly changing? So I'd be really interested in your thoughts on that. I'm very conscious of the time, so what I might do is sort of add question 3 to that, which is, what do you think that you could do differently now? So question 2 and 3 are sort of merging, which is, of the adaptations that you're seeing, what kind of possibilities do you think we could spread and sustain, and what could you do differently now? And I'll let you respond to that. Some people who've been name checked in the chat rooms, I would totally and utterly agree with. There's a Nikki, you mentioned the ABC chats. They are fun. They're on the Kaleidoscope YouTube website. They've been really fun to listen to, but also pretty damned insightful for a very short amount of time. It was only 30 minutes, but they've had some. I think you mentioned the guy that talked about complexity, which I thought was fascinating. And today David Haslam has been talking. But obviously the other name checker has been Stephen Shorrock. I think he is one of the most insightful people that I've ever come across. So if you don't know Stephen Shorrock, I'm going to type his name into the chat room. You can find him, again, he has his own website. And he talks an awful lot and very eloquently about the difference between work as done, work as imagined, work as prescribed, work as disclosed, and many and much more, and really brings safety to life, as does people like Sidney Dekker, and the work that he's been doing with people like the Mersey Care Partnership Trust in relation to a just culture, because underpinning safety too is the need for a just culture. So Paul, I'm going to put you on the spot and see if there's anything that you spotted that drew your eye to.
Yeah, no, but there's so many interesting points being brought up. It is hard to keep up, but I did make a note of a few kind of themes that I think are related. I think both Donna and Gillian at least mentioned about the importance of the flexibility of the roles that people are being asked to do. And linked to that, then I think Claire mentioned about recognising the psychological impact and the well-being of people. And I think this is from conversations that I've had with some healthcare professionals, is afterwards in terms of what are we going to learn, if we do need more flexibility with within our teams to be able to adapt and overcome, then what support are we providing them in terms of training? And as an organisation, do training curriculums need to be revised? Do training programs need to be extended, so that otherwise people are put into a position that actually is unfair, or creates a degree of anxiety that people are actually walking away from the profession? So I think from an organisational point of view, from a leadership point of view, we need to look at how we're going to protect those people if that's the change in behaviours that we're looking to see going forwards.
Lovely, brilliant. I think you've also reminded me of so if we do think about a safety one world, which is very much looking at failure, and we know that we do have to do those things, there is something really wonderful about looking at that with a safety two lens. So if you are going to look at incident reporting systems and investigations, then using a safety two lens at looking at those, plus the ability to understand complex adaptive systems, means that your investigations will actually truly start to find out what work is like, how we adapt it, how it might fail in certain circumstances and how it succeeds in others, and how therefore we can then start to think about how we might look at the system as a whole to do something differently now. So it isn't, oh, let's just stick to doing the old safety one stuff and kind of, you know, shoehorn safety two into it, on top of it, or whatever. It is about changing both and blending them together. I don't know if that's how you see it, Simon, in terms of your resilience work that you've been doing. Sorry, Simon, you're muted, so I didn't get to hear that. I do it all the time. If you could, I'll unmute you, shall I? Can I unmute you? No. Matthew, is there any way that you can unmute Simon?
Hi, can you hear me now?
Yeah, you're going to have to start all over again, Simon. Thank you.
Sorry. Yeah, I think, you know, quite a few people have been raising points similar to this in the chat. This idea of moving from rules and compliance in the old safety one way of working into a period where we're having to flatten hierarchies. So Margaret, Joanne, Ben talked about this idea of flattening hierarchies, and how can we flatten hierarchies, make decision making much more local, and being able to take more responsibility at a local level. And it's almost seen as acceptable at the moment in crisis, but how do we retain that when we move out of crisis and we move into normal? So how, and this is going to be a huge debate, and I think another point raised, I didn't catch who it was from, but point raised about, you know, has the lack of staff empowerment really made a difference to our response, and will we see a difference in organizations where there was significant improvement in that area versus where there hasn't been, and being able to look at the staff surveys, and maybe looking at the NHS staff surveys to see the differences between how people have approached it. Different trusts have approached this, but to me, what underpins the whole of safety two and resilience is this aspect of empowerment. How much do we allow our staff to make their own decisions, to be flexible? And I know I've noticed there's a couple of people from aviation, and this challenge from aviation where they, you know, if you've got very strict procedures in a cockpit, how can we start letting people divert from those strict procedures? And it's something that we've really battled with in aviation, and you know, in time of crisis, then we really need to understand that. But equally, when we move into normal, when we head back into a non-pandemic situation, what lessons can we learn from this, and how do we change the way we empower our teams?
Yeah, I don't know if you've I'm sure you have read Team of Teams, and what you think about that book in some respects and its lessons in relation to enabling people to work as a community separate from the hierarchy. Have you read that one?
I think, you know, this idea is so critical, because we're essentially the hierarchy is on one level is very clear, but undoubtedly one of the things that this crisis has shown is the number of informal networks, and where people really get their information is not through the hierarchy, but it's from people they know, people they have contact with, and this idea of drawing out the informal network is really important, and how these communities of practice are developing really ad hoc at the moment. But I mean, the other thing that we've seen is that this is the first time we're really testing this new world of technology, this idea of how quickly we can share information with WhatsApp, and someone else mentioned Trello being used as a way of keeping colleagues that are at home informed of what's going on. All of this is completely untested in this kind of crisis. So this is a whole new world that we're going to have to adapt to, and we're going to undoubtedly take these informal networks and these informal communities of practice to really make an improvement to the way we do things going forward.
Yeah, absolutely. It fascinates me. And one person made a lovely point, which is incident reporting in their organisation may be on the decline, but an increase in excellence reporting has gone up. And so, and we know that the learning from excellence scheme, for want of a better word, has really been embraced by in particular the clinical community, but others, as a way of really and showing people kindness, but also pointing out to them their brilliant performance, and asking them to think about reflecting on that, and that usually has led to them wanting to replicate it and then continue to strengthen that based on some really lovely feedback. And so that is absolutely one of the other lovely things that can be brought into this whole mix. I was quite fascinated with myself in some respects, in that I worry about regulation and its impact, and I worry about hierarchy, and I've studied Marshall Gans and his theories on leadership, and how leadership is a responsibility, not a role, and you can and the importance of the diversity of opinion and people and thought. And then I was shocked by my own feelings but in certain times of really big crisis, there is this element of command and control that you need to keep us safe. So as we're sitting in lockdown, or however we want to describe it, that you couldn't get a more bigger command and control request, and how that is trying to do it from the respect of keeping us all as safe as we possibly can. And it's just made me rethink that like all things in life, and polarity mapping shows this beautifully, there's good and bad of everything. And so if you ask yourself what's the good and bad of command and control, you can find the good and the bad, and so on. And even if you can use that whole way of thinking by even taking something that intuitively you think is really bad, like incivility or bullying, and then you can ask yourself crucial questions about, but what would be the benefit of being in civil? You know, the benefit of being in civil would be, let's say you see somebody collapsed in the street and you elbow your way through everybody going, look, I can save this person's life. You're being completely incivil and horrible to somebody at a certain point, but you're doing it for the outcome of saving someone's life. I'm just taking an example. So it is about us not being drawn into that even linear thinking of everything's black or white and good or bad, and that there's benefits for all of the things that we do, as well as the downsides. And it's being totally cognizant of all of that, and I think that needs to be brought into it. I'm going to time check 13:16. So brilliant. What we'd like in the next bit is to actually just explore what else you would like us to explore, because as we said at the beginning, an hour is never going to be long enough to do all of this. And I think what it would be really lovely if you could pop in the chat box some crucial things that you'd like this to be followed up with, whether that be another Zoom or more Zooms, or different ways, or whether you'd like that to be in small group Zooms or just a large group again, or whatever. So there are ways in which you've been working and adapting in your own organisation to gain knowledge and understanding. What would you like from us in order to do that as well? And how can we learn from you? So we want to explore what other aspects of ways you'd like to connect. What would you like more of? Anything you want another Zoom on, and would you prefer it in small group conversations or large groups or both, and so on. So a quick pop that into the chat room. That would be really lovely about what next steps could be. And then I'm going to ask Simon and Paul just give you a minute of reflection to think about. I know, I hate this question, but it's kind of, what is the one thing you'd like to leave the audience with? And I know that's horrid because there is no one thing. I know that. But what is the one thing that you would like to leave our participants with? Giving you at least a minute to think that through, because I'm somebody who needs that as well. And Matthew, as I understand it, you're thinking about, or you're going to collate a feedback survey so that you're going to send that to the group who've joined, and also the people that registered, in order to get a sense of what you would like in the future. And there's the, as you would have been sent in your email, also the ability to join the Organisational Resilience and Safety 2 group, and you would have been given the link, and we're going to again refresh those for you. So let's have a quick look to see what people would actually like.
If you want to have a look, I think I can probably reflect on your question. Actually, one of the things that people often say about Safety 2 and resilience engineering is that it's still theoretical, and you know, how can we really take practical solutions? And I think that Joe just gave us a perfect example of how you can really make this simple and easy, and a really good way of doing it. And that is just pause before you send an email. Everyone's busy, everyone's inboxes are full. If you summarize and you really make sure you focus on something that's helpful, actually that's Safety 2 in action. It really is making sure that what we're trying to do is we're trying to give people time. We're trying to really encourage what is working. And just a point made by a few people in the chat is, you know, just asking how things are going well, as well as what can we do better. And those very simple things are just things that we can do, as well as what has been mentioned a few times, just listening and making sure we keep our ears open for anything that we can do to improve the situation. But yeah, that's a very quick summary of my.
Thank you. I've also noticed that from, I'm going to say this completely wrong, Yvonne from Norway, or in Norway, a small pilot implementing Safety 2, perhaps you'd like to try, and they've given you the link, and the RPET, which is our repeat, Eric would say, a tool that Eric Hornagel has developed, is a really interesting, useful tool. It's to us in healthcare, it sounds very similar to huddles or debriefings, but it's basically gathering people at the end of either a day or a shift or a week to do just as you've just described. Ask ourselves what went well today, what would you like the next shift to know, what would you like the people tomorrow to know, and what would we like to do differently tomorrow. Those kind of questions to really truly ground ourselves in the here and now learning. And Eric's tools are starting to explore how we might sort of bring to life that. And there's the work of Jessica Mesman, who's a professor in the Netherlands, and she talks about a video reflexivity, which is a very long and complicated word for basically videoing the mundane. And it's a way of noticing the unnoticeable or noticing the ordinary stuff that you do. So if you video stuff that you do every day, you can start to notice how differently you might adapt it according to circumstances. And so her work is growing in terms of what we're learning about how we work and work is done. Lots of people are saying more Zoom groups, lots of people are saying large and small, and so we're getting pretty much everyone saying yes to pretty much everything else, which is great. But if we can have some really particular focus down, I think that would be great, because safety too is a really big topic, as is resilience engineering, as is all the work that people have been doing on this call. And so I think it may be that we might want to focus it down a little bit more. Let me just double check that I'm not missing any.
We can continue. We can continue this conversation in the special interest group. So, Matthew, if you could share the link again to the special interest group. But we have a special interest group that's focused on organisational resilience and safety too. So there is an opportunity there, and we will. There are already resources on this. There are the references that we've spoken about, and I'll add more to it. So any of you that are Q members that are, would like to get access to that, but equally, if you are not Q members and you would like access to any of it, then please just drop us a note, and we will attempt to get access to that to you. I think the other aspect is there are other organisations. So the Resilience Engineering Association is running a webinar series about learning from the crisis. So please, there's one coming up on Monday, which is going to be very interesting and very multinational. So I suspect we'll get some insight through that one as well. And again, we'll make sure that we log these on any opportunities for learning on the Q website. So please keep an eye on that, and join in, and we'll continue the conversation and try to do, as you say, Suzette, to try to work out, if we're going to have multiple new Zooms, how do we pull it apart? Do we have a Zoom on by sector? Do we have a Zoom by clinical versus managerial adaptation, and so on and so forth? So I'll be going through the chat and trying to consolidate a way forward with the rest of the team that have organised this. Yeah,
and I'm very, very taken by some of the very, very insightful. There's one here from Kat Harrison. Hello, hi Kat. I'd like to explore the ongoing framing of the value of adaptability. The current level the crisis has demanded is taking a toll. So is there a risk that standardization and a false sense of stability would actually feel more appealing to those exhausted? I think that's a fascinating comment to make. And how a better balance of empowerment and control can be maintained after the crisis. I think if absolutely, I couldn't have put that better. So that, and in some respects, one reason why safety won, if we has persisted for so long, because it's what we're used to, it's what we have got our habits into, and what we feel more comfortable with. And so that's what we tend to do as human beings, don't we? That we stick with what's the easier thing to do, and to go back with some level of security when everything has been so changeable that we may need to be kinder to people. It brings me back to the things that I said right at the very beginning, this is about recognising wholeheartedly the situation that everyone's been through, and not to go, oh, how exciting, we're going to all now move on and do something really, really different. And so this is we need to take our time to do this if we think it's the right thing to do. Paul, I need to give you your time for your one thing reflection.
Well, one thing to sum up all of those things, Suzette, thank you. I think just going through the chats, there are a few themes that have come up that I think are really important. The importance of trust and compassion has been consistent throughout the chats, and I think that is what underpins when I know you talk a lot about the importance of a just culture, and I agree completely about that. I think if we have an approach that is compassionate, civil, and empowers people with trust, then I think we're a big step towards creating that just culture. I think is one, very important for the people that are working there, and two, for the patients and the care that they provide. And just to bring that, because somebody mentioned that some of the excellence which has been shared widely in the chats is not as consistent as maybe everybody would wish. And one of the previous questions before the session was about PPE and reporting and things like that. So I just want to finish by sharing a personal story. And that is that 5 weeks ago, I sat down with my wife, who's a ST7 anaesthetist, who's 9 months into maternity leave, and discussing about whether she was going to go back to work early to support her colleagues and the patients. And we had a very powerful series of conversations about risks that she would accept and the environments that she was working in. And it was so pleasing to hear, as somebody outside of that system, the leadership and the teamwork that was at that hospital and the systems that were created to safeguard my wife and as a result then my family. And I think that's why these conversations are so important, because those little interactions, the things that we consider to be everyday and not important, actually change people's lives. And that's what we want to recognise, value, and make as normal as possible.
That's really lovely, Paul. Thank you for now making me feel really moving. So I get terribly emotional. Does everybody get terribly emotional these days? It must be just me. That leaves me with just 2 minutes to say a huge thank you again to Matthew and the Q community. A big thank you to Paul and Simon for your reflections. Most importantly, thank you to everyone who's joined in and given us some wonderful, wonderful things. And I hope that we'll have spent time looking at everything that you've given us. So you've given us an awful lot to learn from, to think about, and we're incredibly grateful. I hope that we do this time and time and time again, because this is such a lovely way in which to connect. And as somebody said so beautifully in the chat room, it's so incredibly important for us to join together on all of this. We know that that's another thing that the pandemic has done. It's joined together all sorts of people that they didn't know what could be or were going to join together. And the fact that they have is so, so, so wonderful. Thank you for taking the time to be with us, and a huge thank you to everyone for everything that they're going through. And we are continually and always thinking of you all. So I'm going to stop recording now. Bless you all.